iCloud, my iCloud account, and so I switched it over. It's fine, over to Gmail. I saw it was hung up, so that's the reason why, like, the very next day is what I said.
One more day.
Big deal. Yeah, I really enjoyed that article, and I'm looking forward to the cheap Tesla. I might actually, you know, I love my car that I have now a lot.
I mean, we get several years now. So and I was buying maybe 18,000 miles. If I was buying gas, how much would I have spent on gas?
Oh yeah. Oh yeah. Yeah, I just got a Lexus, and it really, it just, yeah. I mean, you can switch it to economy, and it does, now it's the IS 250. It's not.
You take one.
I don't think too often. They had some that were on the SUVs. Then one of the, I know what it was. The one that they showed me was a hybrid. The seat didn't go down, and I need it for my dog. So I need this.
I have a lady, she's from Houston. She's going to have surgery done by a guy in Mount Lake Terrace who does a lot of Ehlers-Danlos folks. She's a documented mastocytosis.
A real Ehlers-Danlos.
A real one.
It'll be the first reported in the literature.
Anyway,
despite what you really
but her tryptases are consistently over 20. She's never had a bone marrow biopsy because she wants to do it under anesthesia. And she's going to have anesthesia for her surgery, so her surgeon wouldn't put her out.
Yeah, I have a protocol.
Anyway,
You want me to send you that protocol?
if you want, I didn't know she's here. She's going to be coming back and forth.
Yeah, it's probably sitting in the guy's backseat.
Write this out because there's nothing inside.
They have it. Yeah.
So anyway, I told her you might want to see her. And so then she's here. Anyway, that's her stuff, but
Yeah, I'll remind you. I'll send you the protocol as it comes out.
okay. All right. But I finally got one, Drew, instead of just
No, it's great.
instead of the pseudo mastocytosis patient. Well, and you bought any new cars lately? Any more cars? And then so she doesn't care if you buy houses or cars. She gets mad when she buys the houses. You get mad when she buys the houses. She can buy it.
I brought my computer today, but I didn't grab
Is that your solicitor?
I do.
Simple wishes better than hard.
I know. I remember you were telling me
So, what's the question?
They pretty much won't do it.
Okay, that's what I need. So I will get that question. More than what's happening.
Yeah.
The other one I think will be done very
I got the papers.
Okay. I sent you an email with.
Oh, okay. I'll double check.
I'll look at it again. Somebody up in Bellingham. I'm not sure what diagnosed. I'm not sorry. I wanted you to contact what I'm saying. Sometimes I actually read this. And then it's suspected.
Okay.
Okay, good.
Yeah, I'll get the chest. Make sure I have it.
My mom got me trained very well.
Also helped us raise some money.
20 years ago, it was sore for
Great help.
It's nice to have everybody down.
I'll do the follow-up.
No, I mean, most of what I've seen is yeah, it's not frequent enough.
Almost the holidays, you got your shopping done?
Great, excellent, appreciate it all.
What are you gonna do if you
Apparently.
All right.
No, like the rest of us are all that.
Watching the dog for a long time. He said to tell you.
Don't call them out.
So the word of the day is Montana.
Just a couple of comments before we get started. I just picked up the new Allergy directory, and everybody in the room, everybody, physicians and everybody with pharma who helped us, if you pick up a copy, just do the sign-in sheet so we don't mail a duplicate, because we don't have the budget to mail them in the first place. I got to get the rest of them mailed out one way or another. And one other comment. I found a good restaurant in Houston, so when we go down there for the national meeting, if you haven't indicated that you want to go to the dinner on that Sunday, they closed the whole restaurant for us, the same model that we had last year, and we just have our own session. One other comment, Drew gave medical grand rounds last week, did a brilliant job of representing and advertising our specialty to the general internal medicine audience. So Nick Compton has kindly, for a couple of years now, come and educated us, and he's going to do it again on an update on pruritus.
Thanks, Lynn. Thank you, Drew. Congratulations on getting that grand round out of the way. For those of you who didn't go, I didn't. I was on vacation last week. You can and want to see it. They record those, and I think you can see them on the Department of Medicine website. You may need a UW ID, but I think you can see those. So I would encourage you to do that if you're interested. So today I wanted to talk about itching. Actually, you guys recommended this last time I was here in April. It's certainly something that we all have to deal with, either personally or in our patients. First of all, I don't have any relevant disclosures or relationships with industry. Today, at the end of the talk, I hope that you guys will be able to, if you're not already, identify the pathophysiological mechanisms involved in pruritus, or at least be able to identify them. Develop an evaluation strategy for patients with itching, and then identify atypical therapies to employ in patients with itching. itching is tough. It's really common. It's probably the most common skin complaint that patients come in with, certainly in my practice and probably in your practices as well. But it's really not very well understood. There's an increased level of interest in identifying the mediators and the mechanisms of itch, so that we can do a better job treating it. I mean, we tend to inundate the patients with antihistamines, which is helpful, but it really only, not actually pun intended, scratches the surface of treatment. But what itch is best defined as the sensation that produces the desire to scratch. We've all had it. Everybody experiences itch at some time in their life, and some people will have chronic itch. The same with urticaria. Acute itch is defined as less than 6 weeks, and chronic itch is defined as more than 6 weeks. About 22% of patients, or 20% of people, will have a chronic itch at some time in their lifetime, and depending on the review, the source, the data, about 10 to 25% of patients that present with pruritus will have a systemic disease associated with that itch, that pruritus. The data on the retrospective data on itching is really not all that great, in part because itch is a really common symptom of a lot of different and disparate diseases, and so it's really difficult to look at retrospective data and get epidemiologic data on itching. Your patients who come in with itch may complain of a lot of different things. They may complain of just itching, but they may describe it more as a burning or a prickling. They may have formication, which is that sense of something crawling on your skin. I've never had a patient come in and say that my itch tickles, but it's in the literature. And then like pain, you can get sensitization. So with chronic itching, your skin, your nervous system, it changes. So you can get peripheral sensitization, and that's really sort of manifest histologically and chemically with increased nerve fibers in the skin, as well as increased sort of neuropeptides and neurotransmitters that mediate itch. And then you can also get central sensitization as well with chronic itching, where again, akin to chronic pain, you can get something called allokinesis as opposed to allodynia, where usually non-pruritic stimuli causes the patient to itch, or you can get hyperkinesis, where usually you get a sort of a higher response to the stimuli than you normally would in somebody who doesn't have chronic itching. So you have somebody that's itching for 6 weeks or longer, their system has changed, and they're much more sensitive to stimuli than somebody who doesn't have that chronic itch. When we think about kind of categorizing patients with itch, I mean, when we see them clinically, we're basically looking at them and saying, okay, do they have itch on totally normal skin? Do they have itch on inflamed, primarily diseased skin, or do they have itch, or do they have itch with skin changes that are secondary, they're caused by scratching or rubbing? And that's really helpful when you're looking at the patient clinically to kind of begin to think about them. But I think there's a lot of overlap in terms of etiologies with that clinical appearance, that in 2007, this international group on itching developed some categories of itch based on the perceived primary source of the itch. and one is here, pruritoceptive, and this would be itch that's initiated in skin from skin disorders, and this would be patients that I see, atopic dermatitis, psoriasis patients, lectins, chronic patients, those patients. The second category would be systemic itch. So these are patients with a systemic issue that's causing their itch. So mastocytosis, hematological malignancies, lymphoma, etc. A neuropathic itch, and this can be either central or peripheral. So a central cause may be multiple sclerosis, or sometimes you see itch in patients who've had stroke. A peripheral cause would be a kind of an interesting itch condition called brachioradial pruritus, where you get itching on the brachioradial aspect of the arms, thought to be related to cervical spine disease. Or something called notalgia paresthetica, which is up in the midline back. So those would be examples of neuropathic itch. And then psychogenic itch, which you probably shouldn't make unless they've seen a psychiatrist. But this would be itch that's really related to an underlying psychological disorder, either depression, anxiety, schizophrenia, something like that. It's important to know, though, or to at least think about, that up to a third of patients who come in complaining of chronic itch actually have a combination of the above. So a lot of them come in with multiple causes, and so it's important to at least think about these categories when you're seeing a patient, and then when you're seeing them back and they're not significantly better, trying to investigate other possibilities. So as I said, itching is really complex, and there is an increased effort to understand it a little bit better. But it does have a lot of similarities to pain, as described by kind of peripheral central sensitization, and in fact, it travels along similar pathways. So there are, at least now, understood that there are at least a couple of C fibers that transmit itch, that also transmit pain. But about 5% of all the C fibers are ones that specifically transmit or involved in transmission of itch sensation. And there's two different types of those. There's the histamine type.
There should be a pointer on the screen.
Oh, yeah, I can just use that. Yeah, right. So there's the histamine type, and it's in blue here. The sensory fibers, I'll just come out. Is it okay? Will people hear me still?
Yeah.
Okay. So the histamine fibers are represented in blue. The C fibers are in the papillary dermis, so the superficial dermis, as well as in the epidermis. And at least experimentally, if you take away the epidermis, you can abrogate the sensation of itch, which is sort of curious. So the interaction between probably keratinocytes and the nervous system is probably very, very important. It's tough for other reasons. But these histamine sensitive fibers are also sensitive to temperature, which is why later on you'll see when we talk about kind of just general things for itch. One thing is to try to keep people in a cool environment. They don't want to get too hot and sweaty. So hot showers are sort of out. Hot baths are sort of out. You want to wear kind of, giving away the punchline, but you want to wear kind of loose clothing that sort of keeps you cool. And probably one of the reasons that menthol helps too on the skin is it creates sort of a cooling effect. But they're not sensitive to, they're mechano-insensitive C fibers. Another itch fiber is this cowage-sensitive C fiber, and it's sensitive to somewhat heat, but it's also mechanosensitive, and so we see patients with atopic dermatitis all the time that may their itching episodes may be exacerbated by just putting on clothes, and it's probably related to these fibers that are hypersensitive and are mechanosensitive. So the sort of pressure of putting on clothing can exacerbate their itching. So anyway, the C fibers come in, the dorsal horn, cross over the spinal thalamic tract, and reach into the thalamus. They're going into the cerebral cortex in similar areas as pain. It's thought that the pain fibers have sort of a tonic inhibitory effect on the itch fibers. And if you have pain in an area that's also itchy, the itch sensation doesn't get up. The pain sort of dominates that. And it's probably in part some of the reason why you get patients that will scratch themselves to bleeding, to pain, is to try to stop some of this itch sensation, the sort of gate theory of transmission to the central nervous system. It's complex and I think still being elucidated. There isn't an itch center in the brain, at least as far as science has figured out to this point. So this is a small list, really, of some of the mediators of itch, and then some of the receptors that are involved both peripherally and centrally. So some of these mediators will work peripherally, some of them will work centrally, and some work sort of in both places. The classic mediator of itch is histamine, and it works on sort of histamine 1 and 4 fibers. Histamine 4 is on T cells and causes T cells to produce more IL-31, which has been found to be increased in patients with atopic dermatitis, and the serum level has some correlation with the severity of itch. Kind of an interesting piece of information. The opioid receptors, or opioid peptides, endogenous opioid peptides as well as exogenous opioid peptides, are well known to be involved in itch. They work both centrally and peripherally, though the peripheral receptors, their role is not entirely clear. Most of the itch response to opioids is thought to be more centrally mediated, and those come in the mu and kappa receptors, with the mu receptor promoting itch, activation of the mu receptor promoting itch, and activation of the kappa receptor inhibiting itch. So that has been used pharmacologically with both mu antagonists and then kappa agonists, though I don't believe the kappa agonist that has been tried is available in the United States. IL-31, I mentioned that briefly, comes from T cells. Is upregulated in atopic dermatitis. Tryptase, of course, comes from mast cells. Serotonin has a sort of not well understood role in itch. It's found in the spinal cord, but as well as in the receptors found in the spinal cord, as well as in the central nervous system, and it, again, has sort of a role, but it's not a well understood role. Blocking the receptor with ondansetron has been used in with variable success, I would say, mostly in uremic and cholestatic patients. Prostaglandins probably work more by augmenting or affecting the response to some of the itch mediators rather than causing itch themselves. And then nerve growth factor is thought to be involved in this sort of peripheral sensitization process in chronic itching, which upregulates the number of nerves and probably also has an impact in the neuropeptides. So some of the receptors that are involved, I'm not going to go through all of them. This one here, though, has recently been identified this is a group of receptors. One of them in mice has recently been identified as possibly a very specific.
Mention the one you're pointing to.
Oh, sorry. Oh, yeah, sorry. The mass gene-related G protein-coupled receptors is recently been identified as possibly a very specific itch receptor, and more information, more studies going into that. I mean, very specifically, just with itch. So I want to focus on another sort of receptor that I talked a little bit with Len about already this morning, is these neurokinin receptors. And these receptors are found peripherally and centrally. Their ligand, their main ligand is substance P, and when substance P, I want to talk about a prepitant. So a prepitant is a drug that is not new, but is newly sort of being looked at for itch. It's approved for nausea, vomiting related to chemotherapy in sort of very short doses, 1 dose for 3 days, and it has no effect on pain, and so it kind of sort of dropped off the radar of some people. But in 2006, a group in Europe looked at it for itching and found that it has a very quick onset of effect and a very dramatic effect on itching. Since then, there's been about 100 or so patients with varying conditions that have been successfully treated with a prepitant. There's some case series. There's no controlled studies on it to date, though there is an ongoing study that's funded by the NIH looking at a prepitant in itching related to Sézary syndrome. Patients that are extremely itchy. The dosing schedule, as I talked about with Len, is still sort of being looked at. As I said, with chemotherapy, they use it 125 on day 1, 80 milligrams on day 2 and 3. And it seems like in most of the patients that have been used for sort of chronic itch, they've been repeating that sort of series about every 2 weeks. It's been effective in a range of types of chronic pruritus. So Sézary syndrome, it's been in prurigo nodularis, uremic, itching, and others. So it's I was telling Len, I think it's kind of spendy. It's $400 for three of those pills, and he wasn't too concerned about that price. But so it'll be interesting to see what the first trial with Sézary syndrome, what the data shows on that. But this could be a game changer for some itchy patients. It may not work for all itchy patients, but for some itchy patients. Emend is the brand name, EMEND, I think. And then I wanted to talk a little bit about cholestasis as well. There's the cause of itching in uremic patients, the cause of itching in cholestasis, the cause of itching in malignancy-associated pruritus. I mean, none of these are really well understood, but as I said, it's being looked at a little bit more. And there's some information on cholestasis that this autotaxin, which is the enzyme that makes this lysophosphatidic acid from a precursor, may be involved in pruritus of cholestasis. How it's involved is not understood. Lysophosphatidic acid can bind to some of the itch receptors, but it also has 6 receptors of it specifically for itself, 3 of which are involved in or can cause neuropathic pain in models, and so pain and itch overlap. So there may be some mechanism there, but autotaxin has been the amount of this lysophosphatidic acid, or LPA, that is found and is available is almost completely dependent on the amount of autotaxin that's available. They've found that one group has found that autotaxin the level of serum autotaxin seems to correlate very well with patients who have cholestasis and itch compared to patients who have cholestasis and don't have itch, as well as in patients who have cholestasis of pregnancy compared to their gestation-matched controls. So it seems to have some correlation with level of itch. And then if you compare patients who have itching from cholestasis versus itching from other causes, it can also help differentiate those patients with a fairly high positive predictive value. So, talked about that. Exact mechanism is not understood. Talked about. So I think more information hopefully coming out, but you're not going to get autotaxin levels on patients. But maybe at some point in the future, if you have a patient who's got pruritus, you're not sure what the cause is, you obviously just get liver function tests, although that doesn't always tell you the cause. But maybe in the future, serum autotaxin levels may give you a hint that this is more of a cholestatic cause or cholestatic. At the very least, hopefully this will help elucidate some of the mechanisms of itch, at least in cholestasis, and then hopefully have more directed therapies for that itch. So when evaluating patient with itch, I mean, you guys do this all the time, but I think a very precise history is important. A complete skin exam is very important in these patients because it can help identify either findings of systemic disease or, at least what I find most of the time, is that the patients have some sort of skin pathology that we're able to at least address and as a first place to start in treating their itch, and then considering a work patients. So the description of pruritus, it's important to really tease out, and again, I think you guys do this well all the time, is it was very important to tease out very specific characters of the itch. Was it rapid onset? Rapid onset is much less likely to be related to a systemic or malignancy. What's the timing of the itch? Is it worse at night? A lot of itch is worse at night, probably related to the brain being more focused on the information coming from the skin when you're not thinking about work or the next patient or whatever. The severity of the itch, the character of the itch. Location is important, generalized versus localized. Any provoking factors, and this can be helpful. For instance, say polycythemia vera. Very classically, about 50% of patients will have pretty severe itch with PV, and very classically, it's an aquagenic type itch, so worse immediately after showering or bathing. How long has it been going on, sort of chronic versus acute, and then any treatments that they tried, anything that they tried. It's important to identify. And then, of course, did it work a little bit? I mean, I can't tell you how many patients I see, not just with itch, but with all kinds of things, and they've tried something and they say, oh, it didn't work. But they investigated a little bit further, and while they were using the medicine, it worked. But then when they stopped, whatever the symptom was, whatever the condition was, comes back. And so in their mind, it didn't work. So I think really exploring what do they mean by it didn't work. And then what the heck do they think it's to? May identify some psychogenic cause with that question. So, I mean, I think, I think other things to think about would be, do they have a history of atopy? What are their bathing habits? Patients, not uncommonly, are taking 2 baths a day and using soap all over, and that's going to dry their skin out, and that can sort of be an important historical fact. What meds and drugs are they on, or supplements? And sometimes you have to ask that, as you guys know, in many different ways. Do they have other allergies, any travel or sexual history? HIV, hepatitis C can cause itch, and then a good review of systems. So just some generalizations from history. Itching that's chronic and progressive is more worrisome for a systemic cause than that's sort of acute itch. Always think about meds, drugs, and supplements. And here's a list of meds that have been associated with itch, right? I mean, any sort of list of meds for conditions can be long, but to think about antihypertensives, anti-lipids, sort of a lot of meds have been associated with pruritus. So things to think about, and when you're thinking about stopping a medicine that could be a culprit, because the timing fits, the timing works out. You want to stop it for at least 6 weeks, if possible, to see if there's a benefit. Another group of medicines that's not on that list are the targeted chemotherapies. So the epidermal growth factor receptor inhibitors, tyrosine kinase and multikinase inhibitors have been associated with itch, and in fact, aprepitant has been used in those patients to treat their itch. Psychogenic pruritus rarely wakes them up. So if they're being woken up at night, having sort of poor sleep, which if any of you guys have not slept for a long time, had a newborn at home, you know that it can cause a lot of difficulties with your life. It's difficult to concentrate. Some patients with bad itch and uremic in nature want to stop hemodialysis because of itch. Like they're just so it impacts their life so much. Psychogenic pruritus rarely is going to wake them up. Again, I wouldn't make that diagnosis without having to see a psychiatrist. And then I talked a little bit about this. So pruritus after bathing may represent cythemia vera. So on your exam, you want to do a complete skin exam, field and lymph nodes, abdominal exam, and then a good thyroid exam. And these are the only few pictures that I have in here, just to show some secondary changes. This is just a good example of really dry skin. And if I saw patients that had bad itch, this is where I would focus strongly on treating their dry skin, and then sort of see what's left after that. This patient probably has ichthyosis vulgaris. This is an example of lichen simplex chronicus, or lichenification. This is a intergluteal cleft. Probably not a very appropriate picture, but thickened, scaly. Actually has some erosions here, presumed to be excoriation if the patient is itching this area or scratching this area a lot. But you see the accentuation of the skin lines within that just indicates that you have epidermal thickening, or what we call acanthosis. And that's just a response to chronic scratching and rubbing. Now, could this be a primary skin etiology that caused these secondary changes? Absolutely. This area of psoriasis would be a great location for psoriasis. But this is all secondary change. This is not primary lesion. This is just secondary change. So you can look at this and say, it's a good location for psoriasis. All I see is secondary change here. I don't see anything anywhere else on the body. You're going to do a full skin exam, look at their nails, and look for other signs of psoriasis. Well, I don't see anything for psoriasis. It's a good place for psoriasis. We're going to really focus on this skin thing here and I would treat with anti-inflammatories. It's red, it's inflamed, and good moisturization. And then let's see what happens after that. Could this be from a systemic cause? Absolutely. But I would really focus on the skin findings first, treat those, and then see what's left over. Dermatographism, you guys probably see this sort of all the time. Always a good idea to check for this on patients who are coming in with itchy skin, especially if they don't have any skin findings. If you can't find any skin findings on your exam, take a pen, or I just use my thumb and rub it on the back. But don't forget to go back and look at it a little bit later, and remind the patient, say, I'm going to scratch your back. I want to take a look at your back. So anyway, and then here's lots of secondary changes in sort of a interesting distribution. This is sort of butterfly distribution, where the mid back is spared. And what we see here are areas of darker pigmentation, you might call it hyperpigmentation or kind of a brown pigmentation, areas of scarring, sort of hypopigmented scarring, still areas of inflammation. There's some redness here. If you push on it, it probably is blanchable, so it's erythema. And then areas of either superficial ulceration or erosion, probably related to scratching. Then here's another example of a secondary change. These are prurigo nodules. Not a great picture, I apologize. But if you biopsy this, histologically it looks exactly the same as lichen simplex chronicus. So it's the same thing, it's just a little bit different. The prurigo nodule, a patient may be more of a picker rather than more of a rubber or scratcher. So they're more picking at things. Prurigo nodules are not a primary. It's not a primary skin condition. It's always a secondary thing. So it may be secondary to a primary skin problem like folliculitis, but it may just be because they have chronic kidney disease on hemodialysis, and they tend to be sort of pickers rather than scratchers. But these are all secondary skin findings, not primary lesions. If you find these things, you can say, well, maybe there's a skin issue, a primary skin issue going on, but we're not finding any primary lesions. So you have to think about systemic causes or other causes for their itch when you see things like this. Primary lesions, we're talking about inflammatory papules, plaques, psoriasis. So the findings of psoriasis, the findings of atopic dermatitis, the findings of urticaria. These are all secondary changes. And then go back to this picture of the upper back. So this butterfly sign, I'm sure you guys all identified that, if you see this area spared, it suggests that it's not a primary skin problem. It suggests that it's a different issue. And these are all secondary changes related to scratching. So
you can't get your hand.
Because you can't get your hand up. So it's important to ask them what they use to scratch. So if you see that their mid back is involved, but they're using a back scratcher, or they're using the wall or the door jamb or their spouse, then they may have changes in that mid back, which may lead you to believe that they have a primary skin issue. So mid back lesions suggest a primary skin disease. And if you don't see any primary lesions, I think you strongly have to consider that this could be a non-pruritoceptive, so not coming primarily from the skin. And I would say, I think my one key point would be if you find anything remotely suggestive of a skin finding, primary or secondary, I would try to really be aggressive in treating those first. And kind of see how the patient does, knowing that in a third of patients they're going to have more than one problem for their itch or more than one cause for their itch. So I would say the vast majority of patients that I see that come in with itching, I'm a dermatologist, so it's obviously biased, but I can find something on their skin that could be related. Often it's just a generalized dry skin. Not even as severe as that leg that I showed you that first picture, but just some generalized errosis. And dry skin is itchy skin, so really be aggressive in trying to control that dry skin, and again, sort of see how they see.
How often do you end up treating them for scabies? Because the hard part is we don't have the access to do the look, and I'm always looking here, but I don't see something, and then. But I personally have had 3 patients. I had one woman that came down from Canada. She'd been itching for 2 years, and she ended up having scabies. I sent her to the dermatologist, and that's what they figured out was her itching. And then I saw another woman who was on prednisone through a dermatologist for 6 months, and then they figured out later after her granddaughter got scabies that she had scabies, and they did not have the typical stuff. So then I'm like, well, maybe I should just treat people.
Very quick, I think for me it depends on a lot on distribution and then history. So certainly if somebody else is itchy, though, remember that it can take up to 30 days before somebody who has been exposed to be itchy. So they may have developed scabies and none of their close contacts have had it long enough to sort of be itchy. So certainly with that history, that'd be an important historical information to identify. And for me, it's also sort of distribution. So scabies typically will involve sort of the areas. If you take a circle with your kind of belly button in the center, and it goes to your wrists, your nipples, and your knees, that's where scabies is. Scabies is not on your head, scabies is not on your feet. And so with that, sort of those distribution, if they have like penile nodules, and without, I obviously will always scrape them because I have that capability. But even without it, they have a good story and that distribution, then I'll treat them. Have I been fooled? Yes, absolutely. I had a patient when I first got out of residency at the VA that I thought for sure had dyshydrotic eczema on her palms. She had the little vesicles on her palms, and I was giving her topical steroids and whatnot. And she came in and saw a Greg Rauji who did scraping and found a bunch of scabies on her. And I was getting ready to think about light therapy and all this sort of stuff for her.
Well, and that's the other thing is how do you convince the dermatologist to do scrapings? Because I swear, I'm sorry, but I don't. I've sent people, I'm like, can you rule this out? And then they say, oh no, it's not that. But I'm like, but that one woman was on prednisone literally for 6 months. It's a crime.
Well, I think you can't force a surgeon to operate.
No, I know.
But I would say this may be entirely biased and entirely sort of ivory tower, but I would say it's much more likely to happen at the U or at the VA where you're training people than it is in a busy practice that takes time and doesn't reimburse very well. So I think that would be my comment on that. It's tough. It's hard. But it's also why clinical medicine is nice compared to, say, radiology or pathology, where we get a chance to see patients back and see how they're doing or how they aren't doing, and a pathologist or a radiologist, they have that one point in time. Tough question. Yeah, it's hard. So you see a patient, they've got itch, they don't have any skin lesions. What are you thinking about? Renal, nephrogenic would be the far and away the most likely cause for itch without rash, so chronic kidney disease. Liver, interestingly, mostly cholestasis. Other liver disease usually doesn't cause much in the way of itch, though hepatitis C in and of itself can create some itching. Usually it's a cholestatic picture. So malignancy, we sort of really think of Hodgkin's lymphoma, but other lymphomas. I mentioned Sézary syndrome earlier. Cutaneous T-cell lymphoma without Sézary certainly can be itchy. Leukemias can be itchy. Polycythemia vera, and then solid tumors, of course, are associated with itching, so much less commonly. Endocrine conditions, specifically hyper and hypothyroidism. Hypothyroidism probably just because of dry skin, so it'd be really aggressive on hyperthyroidism. Usually sort of heat. Parathyroid can also abnormalities. So in renal disease, one of the proposed mechanisms of itch is hyperparathyroidism, secondary hyperparathyroidism, based mainly on the fact that in some patients that have had a parathyroidectomy, their itching improves, itching gets better, but levels of PTH haven't really been associated with severity of itch. HIV can cause itching, psychogenic, and then of course medicines and drugs, that long list of meds. So these are things that you kind of be thinking about, and your workup would be sort of directed towards those things. So I think things would be definitely reasonable to do a CBC with DIF. Some people will add a CRP and ESR. So thyroid function tests, liver tests, and chemistry panel, obviously looking for liver disease and renal disease. Hepatitis C and HIV serologies. I think HIV serologies always a good idea. Recommended by the CDC at least once in your lifetime, and then depending on risk factors, maybe more often than that. These I would think more sort of maybe a secondary lab evaluation. Check those first things, see what you get, address findings that you see on exam. Things aren't better, then maybe this would be a second order evaluation. And then, chest X-ray looking for sort of lymphadenopathy, UA, and occult blood for malignancies. Other things to think about would be, if the history is right, travel history. You might think about a stool O&P. So, talk a little bit about specifically renal disease. So pruritus happens in chronic renal disease and not acute renal failure or acute renal disease. So it's really in patients who have severe chronic kidney disease or on hemodialysis. Hemodialysis is more commonly than peritoneal dialysis, and in hemodialysis, it's gotten better with better dialysis. The mechanism is not well understood. There are increased levels of histamine in patients with chronic kidney disease, though, and the level does seem to be somewhat associated with the severity of itch, but antihistamines in this group of patients is almost uniformly ineffective, certainly at sort of usual doses, but if you push the dose quite a lot, you can get some benefit, but you're probably not going to make a significant impact on their itching. But it's certainly worth a try pushing some of those medicines. There's a thought that the opioid peptides and opioid receptors may play a role in renal nephrogenic pruritus, based mainly on the use of mu receptor antagonists, so like naltrexone, has been effective in nephrogenic pruritus, as well as the kappa receptor agonist. Xerosis is very common, or dry skin is very common in these patients with renal disease, and so that probably contributes as well. Or maybe other mediators that haven't been really sort of identified yet. So renal disease can be generalized more commonly, but also can be localized. It usually peaks a couple of days after hemodialysis and can be actually very severe during dialysis. For liver-caused pruritus, and again, that's mostly, almost exclusively cholestatic liver disease, is often generalized, but the hands and feet can be only the areas involved, can be the initial areas involved, or are often the most severe areas involved are the hands and feet. So palms and soles in cholestatic pruritus. Can be migratory in nature. Tends not to be relieved by scratching, and then can be associated with some other signs of liver disease. The etiology in liver disease is not well understood. Bile salts is commonly thrown out there as the cause, in part because cholestyramine seems to have some beneficial effect, and they probably are involved in some way, but may not be the only primary mediator of itch in these cholestatic patients. The autotaxin LPA pathway is probably involved, but again, how it's involved is not well understood. It's also thought that the mu receptors, opioid receptors, may also be involved in here, again, based mainly on the fact that you give patients a mu antagonist, and you can see some improvement with these patients. So malignancy and pruritus, pruritus can be a presenting symptom, or it can be sort of more of a late symptom of pruritus. Again, if you have somebody that has more of a chronic progressive itching, you're going to be more concerned about a systemic, especially malignancy cause versus sort of acute onset itching. It's often generalized in nature, can be really severe in Sézary syndrome patients. And again, I feel like I sound like a broken record, but the mechanisms of itch in malignancy are not very well characterized. Maybe something that is excreted from the tumor itself. Maybe some way that augments histamine or sensitizes the nervous system to that itch sensation. As I said, Sézary syndrome, there's a study right now of a prepotent, a neurokinin 1 antagonist in Sézary syndrome, so it'll be interesting to see if that pathway is significantly involved in Sézary patients for future treatments. So I think in terms of treatment in general, I started to talk about this already before, but you want to set up their environment to decrease the stimuli for itch, or decrease those things that we know in patients with chronic itch are more sensitive. They're sensitized peripherally and centrally to try to kind of avoid things that may exacerbate their itch. So like harsh products on their skin, wool, for instance, right? I mean, even people that aren't itchy put a sweater on, you're gonna start itching. So light cotton and light synthetics are breathable synthetics are really the clothing that they wanna be using. You want to avoid excessive bathing and cleaning. So when I talk to patients about bathing habits, once a day is plenty. They don't actually have to bathe every day. And then using soap everywhere on your body is unnecessary. And see this, my practice at the VA, I see a lot of also older veterans who, a lot of them have itch and a lot of them have dry skin. And soap, even the moisturizing Dove body wash, still dries your skin out. So you step out of the shower and you're already behind the 8 ball. So I tell patients just to use soap in their stinky bits. So their underarms are growing their feet. They don't need it elsewhere. If they've been working on the car or whatever and they have grease that won't come off with water, they can put soap there, but they don't need soap everywhere. When you get out of the yes, go ahead.
Most soaps are alkaline. Is there any value to using the things like the glycerin soaps?
I don't think so. I mean, there's still, especially if a tendency towards sort of dryness, you're gonna step out of the shower drier.
But don't towel off.
I think limiting the amount of soap, limiting the locations of soap is very important. When you get out of the shower, instead of really rubbing yourself really dry, which the rubbing can then sort of exacerbate some of this itch and dries your skin off. So you dab yourself dry so you still have a little bit of skin on. Get a moisturizer that you like, and I tell patients that the best one is the one that they'll use. Though in general, lotions are less moisturizing than creams, and creams are less moisturizing than ointments. But gosh, who likes to put Vaseline on after a shower? So anyway, that's kind of sort of my spiel. And I think that's a really important piece for patients, is to be really aggressive in moisturizing their skin, especially even if you see just a little bit of dry skin on your examination. So use emollients often, at least daily. Best if it's done within 5 minutes of your bathing or showering. Have them cut their fingernails short. Try to trim them back so they just can't sort of pick as well, and then keep them cool. So try to avoid saunas, avoid going to Hawaii. Just try to keep cool. You do that by keeping the temperature down, using sort of breathable clothing, cotton. But also you can do that using menthol related creams, which cause vasodilation and a sort of cooling effect in the skin. And then if you're considering medication as a possibility, stop the drug, but you need to stop it for a sufficient amount of time, and I would say at least 6 weeks. When we see patients with like a chronic rash that we think is related to drugs, we have them stop for 3 months. to try to see if there's a correlation. So with itching, the recommendation is just 6 weeks. So some topical therapies that can be used. So topical anesthetics certainly can be very effective in localized pruritus. Certainly wouldn't do it in somebody who has generalized pruritus, too much body surface area involved. But they can have a really positive effect. They're not going to be the only thing that you're able to use, but it's something that you can use in your armamentarium for localized itching. Mentioned menthol, the camphor and menthol lotion called Sarna is sort of a mainstay in dermatology practices for treating patients with itch. Again, it's probably going to be more helpful in patients who have localized itch, just because the body surface area you're having to apply. But it's certainly a reasonable adjunct in patients who have more generalized itching. Capsaicin cream. So capsaicin, works through depletion of substance P, but initially you get that sort of burning sensation. So you really have to counsel your patients through that the first several days. They may have some burning and inflammation in the area, which is actually very similar. You can see this in tacrolimus and pimecrolimus as well. They also do the same thing by depleting substance P. So these would be some options, I would say, again, for more localized disease. It's going to be hard to get these topicals on for generalized disease, though I would say camphor, menthol would be ones that could be used. They can be used as often as needed throughout the day, though their benefit is fairly short-lived on the order of minutes to hours. So one modality that I think works really, really well in lots of different kinds of itching is ultraviolet light therapy, and narrowband UVB is the one that we use mainly. It has certainly a decreased side effect profile compared to UVA, as well as broadband UVB, and narrowband UVB will be found in any dermatology practice that does light therapy. How it works, again, is not very well understood, but probably has some effect on mast cells, Langerhans cells, and the inflammatory arm that's involved in itch, maybe the IL-31 pathway, tryptase, etc. It works like gangbusters in nephrogenic itch, and so patients with nephrogenic pruritus, this would be something that I would strongly consider in all the patients if it's available, if it's convenient for them. It's 3 times a week, but depending on their skin type, the treatments can be short. I mean, they can start anywhere on the order of about 50 seconds up to a couple minutes, and then increase over time. But this can work really, really well in nephrogenic itch, and I've used it in itch of unknown etiology, and I've used it in patients with hepatic pruritus as well, with really good success. There's some evidence that acupuncture can work in nephrogenic itch. Hasn't been studied in other itch. I've never used it, but if you have somebody that sort of leans that way, that's maybe an option. So systemic therapies, this is kind of would probably be the order of things that I would think of just pills. I mean, I would have ultraviolet light up near the top of this list, but in terms of just pills, this is probably the order in which I would try things. So gabapentin and pregabalin have been shown in randomized controlled trials to be effective in patients with uremic itch. The dosing schedule for this varies, but can be as little as 300 milligrams 3 times a week, or 100 milligrams 3 times a week, or even 100 milligrams a day. You have to watch out, of course, for sedation. Pregabalin would be sort of a second try if the gabapentin doesn't work again. It can be sort of lower dose, maybe starting at 25 milligrams. Naltrexone would be probably my next dose, next medicine that I would try, and that would be 25 to 50 milligrams a day. This is the kappa agonist, this nalfurine, and it's not available in the United States, as far as I can tell. It's not available in the United States, but that one actually has fairly good data behind it, with a beneficial effect on nephrogenic pruritus. These would probably be tossed up. Ondansetron, it has a very low side effect profile. If it's going to work, it's going to work fairly quickly, and so you don't have to do a very long trial of it. 4 to 8 milligrams 3 times a day in patients with itching. And if they're not having much benefit after a week or two, just move on to the next thing. And this one has sort of variable benefit in 5 trials looking at it in cholestatic and uremic patients. So because of the low side effect profile and fairly quick onset and ability, if it's not working, to sort of move on, that's why I would put it there rather than somewhere down the bottom. So mirtazapine has been shown to be effective in a variable number of types of pruritus, including nephrogenic pruritus, and so that'd be another possibility. And then, of course, transplant fixes their renal problem and has a fairly dramatic effect on their aging. For patients with cholestatic liver disease, again, another list. And this would be the order that would be recommended, starting with ursodeoxycholic, especially in patients who have gestation-related cholestatic liver disease and pregnancy. Cholestyramine, again, thought to be the sort of attacking the bile acids as an etiology for systemic therapies. Rifampin actually works really, really well. There's a concern in long-term use of hepatotoxicity, but systematic review looking at that didn't show any liver abnormalities over long periods of time of use in chronic pruritus patients. So I think certainly a reasonable option. Again, naltrexone at 25 to 50 milligrams a day. And then the SSRIs, so that's this impact of serotonin on itching. Sertraline and paroxetine and mirtazapine have shown some benefit in case series with itching, and paroxetine in particular with malignancy-associated itching, but may work in other forms of itch. Again, ondansetron, I wouldn't probably spend a lot of time with ondansetron in these patients. And again, with these patients, I would also have ultraviolet somewhere up on near the top if it's available for these patients. So, sorry, we're over. I apologize. A few take-home points. I think a thorough history is extremely important in identifying potential causes for their itching. Focus on your skin exam in your examination. If you find any sort of skin findings, really focus on trying to treat those, trying to get those better, and see sort of what's left over. I would do a workup in patients if their itching is unexplained, or you don't find any skin findings on exam. It's persistent after treatment of the skin findings, or the findings of systemic disease are identified on exam, tears, nails, whatever. And then just think about some of these atypical therapies in patients with itching, other than antihistamines. I don't have antihistamines on the sort of treatment protocol, but I think it's a reasonable option to start with those. But you really got to push the dose in these non-histamine, primarily histamine-driven conditions, urticaria, mastocytosis. Things other than that, you really got to push the dose in to see some benefit. And of course, there's a lot of side effects with sedation. Sorry that I ran over, but if there's any questions, happy to try to answer them. Yes.
If you have these people and you're treating them for pain, like with the dorsal column stimulator or a nerve block, does that get rid of the itch too?
I suspect it would. I mean, you have, well, that's a good question. Actually, it's a good question because you're blocking the pain. That's a good question. I don't know the answer to that. I'll look it up and I'll email Lynn.
Sort of on the same topic, I'm curious about the chronic sort of neuropathic itch. We see a lot of chronic urticaria. Most patients won't express the urticaria, they're fine, but there are this handful who have had it for years that keep itching. There's nothing on their skin. We do a workup for other stuff, we can't find anything. Do you think they're sensitized? And is there any utility to using some of these meds like gabapentin or mirtazapine?
I mean, I think it's. I was talking with your dad about that this morning, and I think that it's entirely reasonable. If the side effect profile is in favor of a trial, I think it's entirely reasonable to try some of these things because you're right that if you're treating their urticaria, if their urticaria is being treated well, not a reflection on who you are. If their urticaria is being treated well and they're still having itching, and I think there's probably another reason for it or another contributing factor. As I said, a third of patients will have multiple categories of their itch, and so it's entirely reasonable to try some of these other atypical things and see how they work. And somebody who doesn't have kidney disease, so you can push the dose of gabapentin up to 2,400 a day divided. Yeah, I think it's entirely reasonable to do that.
Here's a question from Art Bay who typed in, how does doxepine amitriptyline, compare with mirtazapine?
Yeah, I think there's no comparison. There hasn't been a comparison study of doxepin or amitriptyline versus mirtazapine. But I think doxepin would be an entirely reasonable choice. I think of it inappropriately. I think of it more of just as an H1 blocker, which is not appropriate and it has a myriad effect in a lot of different areas. So I think doxepin would be an entirely reasonable choice. I can't say how they compare with mirtazapine because they hasn't been a head-to-head, but certainly would be one of the, again, I put it sort of just as an antihistamine, and when I think about it in my head, so I would think of that as one of the sedating antihistamines that I would use.
There were some H4 antihistamines being developed. Are those still in clinical studies? Or?
That's a good question. I don't know where they are in clinical studies. I didn't go look at the NIH clinical trials website to see sort of where they are.
You ever find that skin biopsy helps you in this kind of setting?
For a patient that doesn't have any skin rash or describe any skin rash, probably not. Though probably not. In somebody that has some skin findings, yes. Or if they describe skin findings, even if you haven't sort of seen it, then maybe yes. It's best to biopsy something that's abnormal on the skin. I mean, theoretically, you have a patient that describes something that sounds like low pemphigoid, but you don't see anything on their skin. Theoretically, a direct immunofluorescence of normal skin would be positive. In that case, I probably would not do a biopsy. In that case, I would just do serum for antibodies to look for antigens. So, yes and no. Yeah.
And one more typed in question. T cells are involved in atopic dermatitis and idiopathic urticaria. Is IL-31 elevated? First one, just a statement. That is IL-31 elevated in atopic dermatitis or idiopathic urticaria?
In atopic dermatitis, yes. And the level seems to correlate with severity of itching. In chronic urticaria, I don't know the answer to that, but I'll look it up and get back.
Well, thanks again.
Yeah.
This is the last session before the holiday break, and then we'll have Nick back next year for sure, I hope. And our next session is whatever the first functional Tuesday after the holidays is.
If you guys have topics that you want me to talk about please let Lynn know or let me know. This came from you guys. It was better to give you what you want rather than. I'll leave this on this. The reason I sent you the one that I did is in that picture because you know very well. So it's right there. But if anybody wants it, because in the notes, in the notes section, I usually put a lot of notes in the notes section down here. If people want that, there's more information. There's dosing information, and things like that. So if people want that, you might just want to take out pictures. Yeah, we can send the whole thing out again. So they know.
So if you look at
Yeah, I think people would appreciate that.
Yeah.
because even though they're awake the next day, they're with the VA.
So
Yeah.
So it's they're reading all the
I've noticed I take those on rare occasions.
If you have it, write down that you took one of these photos.
What our personal goals are. Those kinds of things. It's really interesting.
Have fun in Hawaii.
Thank you. See you in the new year.
Yeah, that's far away.
The different activities we did.
Yeah.
A couple different things.
I'll just take all
How many are you going to take?
I'll
Four
take
more?
Yeah, and then I'll just send them through the clinic mail so you don't have to pay for shipping. Keep more of the money for donuts and things.
All right.
Yeah.
So that's it. This is where you're running your
Well, I was trying to think of what Milner used to tell us. I mean, was not involved in the area or of atopic dermatitis.
So there's something else in that.
Yeah, definitely something else.
But it's just this is sort of weird humor to associate with all this. So anyway, I took 3.
Everybody get one of these who wants
Yes,
one?
sir. Thank you.